There are a lot of policy updates that pertain to oncology. Last year, the president launched a blueprint on drug pricing, and that had many policies that could potentially impact oncology over time. We've talked a lot about fail first step therapy, which is where patients may have the option to be initiated on more than one drug in one class. And sometimes in managed Medicare plans, they may dictate that patients initiate one drug in a therapeutic class and fail it first prior to going on to another drug. That's a really important policy for cancer patients because, if you have a disease that you're managing like hypertension or reflux, a little bit of suboptimal management is probably okay because you'll have a little bit of consequence. But in cancer, those consequences of failing a therapy first and not giving the best therapy first can truly be grave. And so it's hard because oncology used to be a protected class in step therapy, and this last year there was an elimination of protected classes. And so we're watching this closely and working hard to try to prevent fail first step therapies in patients with advanced cancer. We think that's not in our patients' best interest. And, utilization management as a class is here to stay. That, could be prior authorization, fail first step therapies, other mechanisms to manage utilization, formulary restrictions. Those ways to manage utilization are going to be here forever. But we need to make sure that they don't provide an unnecessary and cumbersome barrier in patients getting the right treatment, especially true in cancer. Because, if you didn't take your pain medication for a day or didn't take a medication to control your migraines for a day, you're not going to die as a consequence of that choice. And that's not true in cancer. If you are on a therapy that is suboptimal in cancer care, it could likely cause your premature death. And so that's been really important for us. Another policy that we've talked about a lot is pharmacy benefit managers. There is a lot of interest in learning more about pharmacy benefit managers, how they manage their contracts, what the spread pricing looks like, what their profitability looks like, why it is that there's a lot of steerage of patient fills of oral medications. And this sort of all in the setting of looking at drug pricing. Is this a vehicle that's causing drug prices to continue to rise? I think that requires further exploration. We always talk a lot about 340B at COA because about 50% of community oncology practices that had been private consolidated and aligned with the hospital systems over the last decade, which causes an important shift in the site of service as those patients now are aligned with the hospital system, which means if you're a commercial payer like United Healthcare or Blue Cross Blue Shield, it costs about double to be served in the hospital site of service in comparison to a private clinic. So we watched the 340B program. The 340B program is a really well-intended program that allows hospitals to purchase drugs at a discount in hopes that they spread those resources over a population in need because our resources to treat those patients are limited. But what we see is because none of those recommendations are statutorily mandated, there's a lot of variability between hospitals and which ones are providing a good deal of care to underserved patients and which ones are not, even within the 340B program. That poses a challenge because that's a $24 billion program in 2018. And so again, as we look at contributors to drug price increase and try to help that problem get better, we need to make sure that we're focusing on the things that really influence change.